I hope this will fix it. Oops.
Okay. Go ahead, Mr. Patterson.
Thank you. Just as a very brief introduction to myself, I have been a member of the Utah State Attorney General's office for over 37 years and have had the opportunity to represent a number of the different departments. Currently, I'm assigned to the Department of Health and Human Services. So with that, we will jump into this mandatory training that has been required by the Utah legislature to be held on an annual basis. I know that for most of you, this will be a reminder, and that is fine. I believe it is part of the intent of the legislature that it be such. The Open and Public Meetings Act is otherwise known as the Sunshine Act, and it does require that all of the state's business be done in public. It has requirements for the meetings, has requirements for notice, it has requirements for voting, and as a reminder, all voting that is valid must be done in public. So let's jump in, and first of all, the act only applies to public bodies. This is considered a public body because it is created by statute. It consists of 2 or more persons. State funds are expended, and it is vested with authority in making certain decisions and recommendations for government. Therefore, it fits the statutory definition of a public body. A public meeting is any time there are 2 more individuals that are gathered with a quorum present to address the affairs of the state and to discuss them. Now, the Open and Public Meeting Act specifically states that chance meetings or social gatherings do not count. And so that is extremely helpful to know. You don't have to worry about not discussing issues that may be before the committee if you're happy to be at a professional gathering or some other location. Now, the notice that must be given, this of course is mostly for staff. The act is very specific. At times it must be 24 hours. There are times where other specific notice must be provided. And fortunately, the staff is on top of this so that the committee does not have to worry about whether or not this particular statutory requirement is met. One matter that needs to be remembered is that the only items that may be voted upon are things that are appropriately noted in the agenda. So those are items where there has been notice given, that there is reasonable specificity provided in the notice and the agenda that helps identify what is the topic, what is going to be discussed, and the action potential that the committee may take. With that criteria being met, then the committee is free to address that particular issue, to vote on it. However, if someone were to bring up a topic in the meeting that notice was not given, that was not included in the agenda, the committee may listen to it, they may hear, but they may not take action. In that particular case, it would be appropriate to take note of it, to have it put on a meeting agenda in the future, and then to vote on it at that time. But again, anything that is not properly included in the notice and agenda may not be voted upon by members of the committee. The records that must be kept of these open and public meetings are quite specific. There's audio recordings that must be kept. Basically, all of the documentation that the public body reviews in making its determination ultimately must make its way into the record and be posted online along with the recording of the meeting. There is specific requirements in the statute for that. Now, as far as the written minutes, the statutory criteria includes date, time, and place of meeting, the names of members present and absent, the substance of all matters proposed, discussed, or decided by the public body. The recording, of course, is something that must take place at the beginning, at the end, and I appreciate the committee's patience as they waited for the recording to be restarted before continuing with the meeting. That is the type of commendable action that the legislature is seeking. So any information that is received by the committee in making decisions ultimately must be included either in the minutes if the comments were public, or if submitted in writing, that must be part of the written record. Now, the Act does allow for electronic meetings, which of course has become much more prevalent the last 5 years. There are certain requirements for that, and I commend the staff for ensuring that those provisions regarding the electronic meetings are being followed and complied with. And just for reference, this doesn't necessarily apply to this particular committee, but there is the opportunity for emergency meetings. There are circumstances that are unforeseen for other public bodies. During those meetings, there is, again, specific notice requirements. There are certain circumstances that must exist to qualify as an emergency. And of course, the failure to comply with those emergency provisions can result in the nullification of the decisions made by the committee. There are also circumstances under which closed meetings may occur. And again, I believe most of the time we don't have to worry about this with this particular committee. There are, however, circumstances such as when employment is being discussed, land deals, certain contracts, reputations of individuals. Those particular circumstances may have closed meetings. However, there are certain circumstances, and I'm confident that the staff will help walk the committee through those circumstances should they arise. The important thing to remember for the committee is that no votes may be taken in closed meetings. If a meeting is to be closed, the facts are discussed, and then when it comes time to vote, then the meeting must be reopened, the record restarted, and the votes again taken in public. Now, what happens if someone violates the Open and Public Meeting Act? In years past, I've gone through various newspaper articles. I have reviewed a few district court decisions. Needless to say, usually the cure is that the public body redo the action, meaning that it renotices it, it holds another public meeting on it, meaning that it's included in an agenda appropriately, meaning that it's discussed again, meaning that votes are taken again, even though that may mean the exact same outcome occurs as originally. There is, of course, one other particular penalty that may occur. The Act does provide that any individual who intentionally violates the Act, then they could be subject to a Class B misdemeanor and up to 6 months in jail and or a $1,000 fine. So while most violations can be cured through redoing the meeting, there is the potential for individuals to receive criminal prosecutions because of it. Now, with that, please keep in mind that open and public meetings does not allow certain individuals to appear before the committee to be disruptive. There are circumstances where individuals may be removed when they become disruptive, when they have an opportunity to conform their behavior, they refuse to do such. Those are circumstances under which an individual may be forcibly removed from a meeting. Fortunately, That does not happen very often, particularly with this committee and with the character of the individuals who are members of the committee, and I believe those that appear before it. So with that, that is a brief overview of the Open and Public Meetings Act. If any of you have any questions, I would invite you to send me an email at tonypatterson@utah.gov.com. I'd be happy to address any of your questions. Thank you, everyone.
Thank you, Tony. Dr. Siegfried. Oh,
Thank you. Thank you, Tony. Well, we can move on unless anyone has questions for Mr. Patterson to the review of ALK, MET, and RET selective inhibitors for approved oncologic disorders presented by Dr. Gonzalez.
Hello. Let me pull those slides up here. Okay. It is echoing a little bit on my end, which might make it hard for me to present here. Is it echoing on your end? I don't hear an answer.
yes,
It is echoing.
yes.
Do you want to try reinitiating the recording?
Try it now. I think it might get better.
Okay. Yep, that worked. Okay, let me get this going. Okay. Okay, so inhibition of ALK, MET, and or RET tyrosine kinases is a targeted treatment strategy for cancers with overactivity or overexpression in these pathways due to genetic mutations or alterations. The 10 reviewed agents are approved for oncologic disorders with ALK, MET, or RET actionable driver mutations. They are orally administered and available as brand name only products. Throughout the presentation and report, the reviewed agents are categorized according to their FDA indicated tyrosine kinase mutational variants. While these agents may affect additional tyrosine kinases, generally they are considered selective for the target and indicated mutation, and in most instances are approved for one mutation type, with the exception of ceritinib, which is approved for 2 mutational variants of NSCLC, as shown on the next slide. Altogether, FDA-approved indications of ALK, MET, and RET inhibitors encompass 5 oncologic disorders: non-small cell lung cancer, abbreviated NSCLC, relapsed or refractory anaplastic large cell lymphoma, abbreviated ALCL, inflammatory myofibroblastic tumor, abbreviated IMT, thyroid cancer, and other solid tumors. A few agents are indicated for more than one disorder. Crizotinib is indicated for 3 ALK-positive disorders, NSCLC, ALCL, and IMT, as well as ROS1 positive NSCLC. Pralsetinib is indicated for 2 RET mutant disorders, NSCLC and thyroid cancer. And selpercatinib is indicated for several RET mutant disorders, NSCLC, thyroid cancer, and other solid tumors. The remaining agents are indicated for one disorder. The ALK inhibitors alectinib, brigatinib, ceritinib, lorlatinib, and ensartinib are indicated for ALK-positive NSCLC, and the 2 MET inhibitors, capmatinib and tepotinib, are indicated for NSCLC with MET exon, abbreviated METX14, skipping alterations. So indications in common between the reviewed agents include ALK-positive NSCLC for the ALK inhibitors and RET fusion-positive NSCLC for the RET inhibitors. NSCLC is the primary type of lung cancer, accounting for approximately 87% of lung cancer cases, Overall, pulmonary cancer is attributed to the third highest cancer diagnosis incidence rate in the US. According to the American Cancer Society, about 230,000 new cases of lung cancer will be diagnosed in 2025. ALK rearrangement mutations and METX14 mutations each occur in approximately 3 to 5% of NSCLC cases. The emerging biomarker MET amplification occurs in about 5% of or more of NSCLC cases, depending on prior treatment with epidermal growth factor receptor inhibitors. ROS and RET mutations each occur in about 1 to 2% of NSCLC cases. The other indication in common between RET inhibitors is RET fusion positive thyroid cancer. Thyroid cancer is attributed to the 6th highest cancer diagnosis rate in US females and is primarily comprised of differentiated thyroid carcinomas, abbreviated DTC, such as papillary disease. Medullary thyroid carcinoma, abbreviated MTC, accounts for 2% of thyroid cancer cases. RET gene fusion mutation is estimated to occur in about 10% of thyroid cancer cases, most often in papillary histology. Because approved indications are also specific to stage of disease, mutational variants, or other clinical characteristics, the indications may not fully overlap. All the reviewed products are indicated for the treatment of NSCLC with indications specific to biomarkers and other nuances. The ALK inhibitors are approved for ALK-positive metastatic NSCLC in adults. In addition, alectinib is approved for resected disease. Crizotinib is approved for ROS1 positive metastatic disease, and ensartinib is approved for locally advanced disease. The two MET inhibitors, capmatinib and tepotinib, are both approved for NSCLC with METX14 skipping alterations in adults. The two RET inhibitors, pralsetinib and selpercatinib, are approved for metastatic NSCLC with RET fusion mutations in adults. In addition to metastatic disease, selpercatinib is also approved for locally advanced disease. Pralsetinib and selpercatinib indications for thyroid cancer vary according to the age for use and potentially by the subtype of thyroid cancer. Both agents are indicated for advanced or metastatic RET fusion positive thyroid cancer that is radioiodine refractory if a candidate for such therapy. However, pralsetinib is indicated for patients 12 years of age and older, while selpercatinib is indicated for patients 2 years of age and older. Based on the indication wording alone, it is unclear whether the FDA's intention for pralsetinib indication includes other thyroid cancer subtypes aside from differentiated histologies, which are typically treated by radioiodine. Comparatively, selpercatinib has a separate indication specifically for medullary thyroid cancer with a RET mutation. We reviewed treatment guidelines by the National Comprehensive Cancer Network, or NCCN, for oncologic disorders. The choice of therapy for NSCLC is largely based on the presence of actionable driver mutations. For ALK-positive advanced or metastatic NSCLC, alectinib, brigatinib, ensartinib, or lorlatinib are recommended preferred first-line options. Ceritinib and crizotinib are secondary options designated as useful in certain circumstances. If not previously tried, lorlatinib is also a recommended subsequent line therapy after progression on other ALK inhibitors because it has some activity, it has activity for some ALK-resistant mutations. Newer ALK inhibitors are also subsequent line options after failure on initial therapy with crizotinib. The NCCN preferred initial therapies for advanced metastatic NSCLC with METX14 are capmatinib or tepotinib. Crizotinib off-label is a secondary option. The NCCN also recommends capmatinib, tepotinib, or crizotinib for high-level MET-AMP and SCLC. For RET fusion positive advanced or metastatic NSCLC, pralsetinib or selpercatinib are preferred initial therapies. However, the level of evidence is rated higher for selpercatinib compared to pralsetinib. Following disease progression on either of these therapies, subsequent options include cabozantinib or non-targeted therapy regimens. For ROS1 positive advanced or metastatic NSCLC, the NCCN recommends crizotinib, entrectinib, or repotrectinib as preferred first-line options, but also notes that in the setting of concurrent brain metastasis, the latter two options are preferable. Following disease progression on a first-line agent, lorlatinib off-label, entrectinib or repotrectinib, if not previously given, can be considered for subsequent therapy. Selpercatinib and pralsetinib are recommended for progressive and/or symptomatic advanced RET fusion positive differentiated thyroid cancer or for anaplastic thyroid cancer. For advanced RET mutant MTC, selpercatinib is the preferred agent, and pralsetinib, with a lower grade of evidence, is an alternative option. Crizotinib is the only ALK inhibitor approved for the treatment of ALK-positive relapsed or refractory systemic ALCL or for IMT. Both indications are for patients 1 year and older. These are very rare cancers in general, each estimated to occur in less than 3 per 1 million persons. For patients with relapsed or refractory ALCL, enrolling in a clinical trial is preferred, or rituximab if not previously tried. ALK inhibitor therapy is a recommended option for subsequent line therapy of ALK-positive disease. Crizotinib, along with off-label ALK inhibitors, alectinib, brigatinib, ceritinib, and lorlatinib are all listed options. The NCCN highlights that because crizotinib does not cross into the CNS, the off-label ALK inhibitors with CNS penetration could be considered preferentially for CNS involvement. For IMT, which is a soft tissue sarcoma, several ALK inhibitors are listed as preferred for systemic therapy of ALK-positive disease, including alectinib, brigatinib, ceritinib, crizotinib, and lorlatinib. All are recommended off-label uses with the exception of crizotinib. Selpercatinib is the only reviewed agent with broad approval for advanced RET fusion positive solid tumors, in addition to NSCLC and thyroid cancer. Among solid tumors, NSCLC and thyroid cancer have the highest prevalences of RET fusion positive mutations, followed by other solid tumors, including colorectal carcinomas, carcinomas of unknown primary site, and breast and pancreatic carcinomas. And NCCN recommendations regarding solid tumors are dispersed among a plethora of disease-specific guidelines. Selpercatinib is recommended for many solid tumors with RET fusion positivity because it has the broad approved indication. For instance, it is recommended for recurrent, unresectable, or metastatic RET fusion positive breast cancer. It is a recommended first-line or subsequent line option for RET fusion positive advanced pancreatic adenocarcinoma, and it is a recommended subsequent line therapy for RET fusion positive carcinomas of unknown primary site or colorectal cancers that have progressed on or following prior systemic treatment. Selpercatinib also has a recommended place in therapy for other rare RET fusion positive solid tumors. I won't go over each one for the sake of time, but out of all of the reviewed solid tumor guidelines, we found only one instance in which pralsetinib, the other RET inhibitor, is also a recommended option. This was in the setting of RET fusion positive biliary tract tumors. Our literature search for direct comparative RCTs of the reviewed therapies for their FDA-indicated disease states in common located comparative studies only in the setting of ALK positive and SCLC. Yet there were no comparative studies that differentiate the NCCN preferred first-line ALK inhibitors from one another. These findings are consistent with the reviewed guidelines with respect to the availability of head-to-head RCTs. The existing studies compared the newer ALK inhibitors to the older, less preferred agent crizotinib and demonstrated improvements in progression-free survival and CNS response. 3 RCTs consistently showed improvement with alectinib over crizotinib for progression-free survival and CNS response. 1 phase 3 RCT each for brigatinib, ensartinib, or lorlatinib versus crizotinib demonstrated improved progression-free survival and higher proportions of patients achieving an intracranial response with the newer agents. Overall, alectinib was associated with fewer grade 3 or worse adverse events compared to crizotinib based on a meta-analysis and individual studies. Grade 3 or worse adverse event rates were slightly higher with ensartinib or brigatinib versus crizotinib and were higher with lorlatinib by greater than a 10% difference compared to crizotinib. All the reviewed agents have a warning regarding embryo-fetal toxicity, hepatotoxicity, and further association with the development of interstitial lung disease. Nonetheless, grade 3 or worse ILD events were generally infrequent. While liver enzyme elevations were common with some agents, particularly with the ALK inhibitors and RET inhibitors, rates of grade 3 or worse toxicity were generally 8% or less for most reviewed agents, except for ceritinib and selpercatinib. Most ALK inhibitors have a warning for bradycardia or for other cardiovascular related events such as hypertension with brigatinib and lorlatinib, risk of QTc prolongation with ceritinib and crizotinib, and rare cases of atrioventricular block with lorlatinib. Except for alectinib and crizotinib, other ALK inhibitors have a warning for the development of new or worsening hyperglycemia. Half of the ALK inhibitors have a warning for their association with visual disturbances or common events of myalgia with CPK elevation. Additional select label warnings per ALK inhibitor are also listed regarding hemolytic anemia or renal impairment with alectinib, photosensitivity and pancreatic toxicity with brigatinib, pancreatitis with ceritinib, common dermatologic hypersensitivity events with ensartinib, and common CNS adverse events and hyperlipidemia with lorlatinib. The MET inhibitors capmatinib and tepotinib have additional warnings regarding pancreatic toxicity. Capmatinib also has warnings for potential hypersensitivity reactions. The RET inhibitors pralsetinib and selpercatinib have warnings regarding hypertension, unusual but potentially severe hemorrhagic events, tumor lysis syndrome, and the potential impairment of wound healing. Selpercatinib also has a warning for QTc interval prolongation, hypothyroidism, and hypersensitivity reactions. Currently, the Medicaid preferred drug list does not preferentially classify the reviewed agents. In the setting of NSCLC, the mutational variant is a key factor that drives selection of therapy. The highest density of indications of the reviewed agents is for ALK positive and SCLC. For the purposes of the PDL, at least one NCCN preferred agent for first-line therapy of ALK positive advanced or metastatic NSCLC may be considered for PDL preferred status. Currently, the NCCN preferred first-line agents are alectinib, brigatinib, ensartinib, or lorlatinib, with crizotinib and ceritinib are secondary in preference to others. There are no head-to-head RCTs available that compare the NCCN preferred agents. At least one NCCN preferred agent for first-line therapy of MET mutant advanced NSCLC could be considered for PDL preferred status. There are no head-to-head RCTs available for these agents. Currently, the NCCN prefers either capmatinib or tepotinib. So for purposes of the PDL, these two MET inhibitors can be considered similarly effective for the treatment of NSCLC with MET X14 mutation. NSCLC primarily and thyroid cancer secondarily are typically the cancers attributed to the highest counts of RET fusion positive disease, together comprising about 74% of RET fusion cases. Currently, the FDA approval for selpercatinib is most broad regarding the scope of indicated solid tumors, whereas pralsetinib is approved for a more limited set of solid tumors, only NSCLC and thyroid cancer. There are no head-to-head RCTs available for these agents. For the purposes of the PDL, at least one NCCN preferred agent for RET fusion positive advanced or metastatic NSCLC may be considered for PDL preferred status. PDL non-preferred products may be made accessible via prior authorization to accommodate disease states and clinical scenarios for which the resultant PDL preferred products may not be approved nor guideline recommended for first-line therapy. You may also consider adding a grandfather clause for patients already started on a therapy. Thank you so much for your attention.
Thank you for the very thorough report. Is there any public comment today?
There is none today.
Okay, we'll move on to committee discussions. Are there questions? Noon, how would you like to handle the establishment of this class of drugs on the PDL?
That's a good question. I think it can be established as the tyrosine kinase. And I think the recommendation from the DRRCs is fairly reasonable.
Okay, why don't we first start? I will make a motion to establish a tyrosine kinase inhibitor class on the PDL, despite the fact that they are not equal in safety or efficacy.
I second.
All in favor?
Aye.
Aye.
Okay, that motion has carried. And now we'll move to the specific inhibitors. I'll make a motion that for purposes of the PDL, at least one NCCN preferred agent for first-line therapy of ALK positive advanced or metastatic NSCLC may be considered for PDL preferred status.
Seconded.
All in favor?
Aye.
Aye.
I will then move on to make a motion that at least one NCCN preferred agent for first-line therapy of MET mutant, advanced or metastatic NSCLC be considered for PDL preferred status.
I'll second that.
All in favor?
Aye.
Aye.
And again, for the purposes of the PDL, at least one NCCN preferred agent for RET fusion positives, advanced or metastatic NSCLC be considered for PDL preferred status.
I second.
All in favor?
Aye.
Aye.
And then I also would like to make a motion regarding a grandfathering clause that current individuals can continue their established therapies prior to the modification of the PDL.
I'll second that.
All in favor?
Aye.
Aye.
Noon, does that cover the class?
I think so. Thank you.
Okay, if there's no other discussion or questions, would someone like to make a motion to close the meeting?
I can make a motion to adjourn.
Thank you.
Seconded.
All in favor?
Aye.
Aye.
Aye. Well, thank you so much for attending. We will see you again on September 18th. And we will be reviewing botulism toxins.
Thank you.
Thank you.